All right, we'll get going. Welcome everyone. Good morning to the latest edition of the Scale Leadership Series that we've been doing for the past 3.5 years on a monthly basis. Anyone who's not on mute, please put themselves on mute. Otherwise, I'm going to introduce everyone to Ira Kornbluth, who's a recent friend that I've developed here at Scale. Ira's a serial entrepreneur in healthcare services and has achieved a lot of success with a particular focus on pain management. And as we always do, Ira, if you could introduce yourself to the group and give a little bit of background on your journey through healthcare services over the years.
Sure. Happy Valentine's Day, everybody. And Roy and team, it's an honor to be with you today. It's a privilege to be here. I'm very impressed with the organization that you've built with connectivity and educational opportunities at scale. So I'll briefly mention my educational background and then explain my journey in pain management. I completed my undergraduate at Brandeis University and then went on to do a master's program at Boston University Medical School. Took some first year medical classes and did a research program there. Stayed an additional year after my master's program, focusing on research on Huntington's disease, and worked a couple side jobs. I was a bouncer in a bar, moved band equipment on the weekends. Probably the most fun year I ever had wasn't in any formal education program. Made $22,000 that year, and I think I never felt wealthier in my life. After that, went on to Jefferson Medical College in Philadelphia, and went in there interested in psychiatry because my dad's a psychiatrist, but quickly realized that wasn't the right field for me. I was thinking about neurology, but I recognized that it was more diagnostic in nature and less focused on seeing improvement for patients from my perspective. And I got introduced to physical medicine rehabilitation, where I saw that there was a focus on improving quality of life, improving function, and that resonated with me. So decided to do a residency in PM&R, physical medicine rehabilitation. Did my internship year in Washington, D.C., went back to Jefferson for my residency, the last year of which I was chief resident at Jefferson. And I was deciding what realm of PM&R to go into for my career. And I got introduced to pain management, which was certainly a burgeoning field at the time. And the best and brightest from PM&R were going into pain management. I asked one of the senior physicians what he thought of pain management, and his comment was, Ira, there's two kinds of people in this world. There's dead people and people with pain. I think you're making the right decision. So understanding the total addressable market in pain, went on to do my fellowship in pain management. I strategically wanted to be near Maryland or Washington, D.C., because I grew up in Maryland and wanted to end up back there. And I had spent my time in Boston and Philadelphia until then. So did a fellowship with an interventional anesthesia division of a hospital in Washington, D.C. Got my hands on a lot of procedures, and then started my career at the predecessor for National Spine and Pain. At that time was called Center for Pain Management. I was one of the first docs there, one of the first partners, but decided to leave after 4 years. I wasn't totally comfortable with some of the business decisions that were being made. So had my wife, who's in commercial real estate, draw circles around all locations. I had a big restricted covenant that pointed to a small town in Westminster. I had never been there before, and ended up going there on a Friday, and decided to buy the real estate and signed to buy the real estate to open my first office the following Monday. And was hard charging, set up an office. I was the first doctor ever to leave National Spine and Pain, so it was a very bold move. Was working really hard. My first kid was born about a week and a half after I started my practice. And then about 8 to 9 months in, I was, working really hard. I was making good connections. I was delivering good medical care, but the business was kind of floundering, and I recognized that. So I called my wife one day and I said, "You need to go up there and fire my manager." And she did. And I had 4 employees at the time. The next week, I fired 2 of the other employees. So I had 75% turnover in a week. It was probably the best business decision I ever made, because I brought in the right people that created the culture and the work ethic to match mine. And then we were off to the races. So we started to open new offices, hired a lot of high quality doctors, and built a very good reputation, and expanded our brand, Smart Pain Management, in multiple counties in Maryland. I was very good friends with the not the founder, but the leader at the time of Cure Pain Management. He was actually a resident when I was chief resident at Jefferson. He was at Penn, but rotated through a few times, so I got to know him a little bit. And we started talking a lot and recognized that our businesses fit together extremely well. So we had considered and met with some investment bankers in 2015, decided that it was probably too complicated to transact and go to an equity partner and say, merge us together. So I decided to let him transact first with his organization, Cure Pain Management. So they went forward in 2015, and then 2017, I joined them. Private equity partner at the time was New Harbor. And that was a very solid relationship. And we went to our docs and other key stakeholders and told them that from our perspective, this was a transaction where it wasn't going to be 1 + 1 = 2. It wasn't going to be 1 + 1 = 3. It was going to be 1 + 1 = 4. And 2 years later, we went back to the table. We transacted again, the highest ever multiple at the time, at least in pain management, which I think spoke to the quality of our organization. And we got a 5x return in 2 years for our partners. So there's, a lot of credibility that we have with our docs. They're, fully bought into the equity model. And then since then, we've continued to grow, have expanded now to multiple states. We're now the largest pain practice in the country. And there's plenty of white space. Even though we're the largest, I think we're probably about 1 to 1.5% of market share across the country. Obviously, we're looking to expand. We're acquisitive. We're well positioned to open more de novos and acquire solid practices. And I think what we're most proud of is, beyond being big, is that we've run a very clean practice. We've run a practice that is well respected, clinically well respected from a business perspective. And we are positioned to continue to be a very big player in pain management moving forward.
Describe to me Clearway Pain.
Sure. So when we were speaking to equity partners or potential partners in 2019, we met with Next Phase Capital, who's our current private equity partner, and they had a holding in Pensacola and surrounding areas of the Panhandle and parts of Alabama called Clearway Pain. It was much smaller at the time than Cure Smart, which was our organization, but it gave us a lot of comfort that they understood pain management, had some familiarity with pain management. Next Phase was not the highest bidder, but we felt most comfortable with them because, first of all, we liked them, but second of all, their familiarity with our industry. So even though the prevailing management is based in Maryland, we made the decision to take on the name and brand of Clearway across the organization as a good faith measure, and to give the providers and stakeholders in the existing business prior to our transaction comfort that we were going to be good partners. we now have incorporated other brands under the Clearway umbrella. Some of those have wanted to maintain their brand in their marketplace, and we have been okay with that. For example, Center for Pain Management Alabama is a very strong brand. So we have branded them as Center for Pain Management, maintain their identity, which is a Clearway company. Same thing in New Jersey and Pennsylvania. We've partnered with a group called Relievus. We've maintained their name and brand in that market. And we, have them positioned as Relievus, a Clearway company. So in each market, we're going to look at it a little bit differently, but we're not averse to maintaining the identity of the brand if it's strong and there's some affinity towards the brand in that marketplace.
Got it. So, Ira, you've worked over the decades for others. You've worked for yourself in an independent practice. You've merged. You've worked with private equity backing now twice. And you've also now led a national leader. How do those different paradigms of ownership, how do you view them? Their strengths and their weaknesses. Some of them get a lot more criticism than others. I know there's nostalgia across the country for independent practices, and there's acrimony and distaste amongst journalists, at least, for private equity ownership in healthcare. What's been your experience? What types of ownership do you appreciate the most, and what are the weaknesses that you see that each of them offer or present?
Yeah, great question, Roy. Well, it's clear to me that the right private equity partner can accelerate an organization's growth trajectory. Private equity brings structure, discipline, financial rigor that independent practices just don't have. Around acquisitions, for instance, the level of diligence and sophistication is much superior to what you would see in an independent entity. So, for example, when I alluded to the fact that Cure and Smart wanted to transact back in 2015, we recognized we couldn't do that without a third party coming in and helping to coordinate the effectuation of the merger. So they certainly have strengths around that. I think private equity is also very good at aligning organizations. The executive that can take an organization from 2 to 10 million may not have the same skill set to take an organization from 20 to 50 million. And private equity can see the capabilities and bandwidth of the executive team. Also, I think equity can provide trusted counsel and support and give an independent viewpoint and some of their wisdom, which again, independent practices just don't have. Before we open a new center, we do detailed projections and periodically revisit those projections to see our performance versus the projections. So these are all, disciplines and skills that equity brings to the table that you don't have in an independent environment. Now, when I was running Smart Pain Management, it was certainly fun and entrepreneurial, but you make a few extra mistakes when you don't have, board and other viewpoints to help guide you along the way. And I think there's this perception that private equity involvement in medical practices is bad and is driving elevated costs. That's certainly not my viewpoint in my experience. I also interview a lot of docs, and there used to be this apprehension amongst docs in joining private equity-backed practices. And I haven't encountered that level of apprehension in the past couple of years when I'm speaking to doctors. They now seem more accepting of private equity. And I think to a large extent, private equity is allowing practices to have a level of independence and the providers to have a level of clinical autonomy that they may not have. So I think that doctors may otherwise be scared and driven into a hospital-based model, and especially in pain management, that's not the most efficient or effective model. And I think that hospitals have some discomfort with private equity because of competition for physicians, and the consolidation of payers, I think, is really driving a good portion of elevated costs. And when private equity backed practices get to a certain size and scale, they can serve as a counterbalance to large payers. I think private equity is good at helping to grow organizations and recognize fat, so to speak, in organizations, and to be able to reduce excessive costs in organizations and thereby drive profit. And I think that's a good thing, is having profitable practices where physicians can benefit and align with the equity organization, and having the right model where physicians and other key stakeholders can participate in the upside in a private equity backed practice is what allows for success and scaling to higher degrees.
So you've been part of the pain landscape for several decades now, and your business has grown and grown to the point where it is a national leader. And along the way, it's been diligenced multiple times by private equity. I personally was involved in one of those due diligence processes myself, and still remember how impressed I was with the level of clinical compliance, infrastructure, and oversight that had been built. Why do so many pain practices, to the point where it's presumed almost for the industry, why do so many pain practices get substance abuse issues, opaque pricing arrangements? Why do they get that stuff wrong? It seems so counterproductive, and it seems almost like an anomaly relative to the rest of the industry. What is it about pain practices that they've exposed themselves to that level of compliance risk over the years?
Great question, and I appreciate your comments about your experience in diligencing our practice previously. So, I think that there's been a paradigm shift in pain management, where pain management is now being redefined to some extent as interventional pain management versus chronic pain management. And historically, referrals were being made to pain management in a couple of different scenarios, and I'm talking generally. So referrals were made after referrals to surgeons for potential surgical conditions. Well, back pain, for example, about 2% of back pain, maybe even less, is surgical. So for the primary care to refer to the surgeon first doesn't really make sense. We can and are happy to evaluate patients and refer to surgeons if it's appropriate for and necessary for them to have a surgical opinion and surgery. The other big way that patients were coming to us is after primary care providers were initiating opioids and then kind of not managing the pain situation with other tools. So to use the analogy, many of the primary care providers were letting the plane take off, but weren't really able to land the plane. So when the plane got turbulent, then they'd make the referral to us. And that's really not the best place for us to get patients, is once they're already on opioids. The best way to prevent an opioid situation with the patient is not start a patient on opioids in the first place. Of course, patients may need opioids, but starting the patient on opioids as an early line of treatment before they're evaluated by someone like a pain specialist is usually not the best course. And especially continuing patients for a prolonged period of time on opioids without offering them other treatments is almost always not the best way. So we're getting patients now earlier in the pain continuum. We've positioned ourselves in large part between primary care and surgeons, and we have really been advocating getting the patients earlier. I think also many primary care providers are now less apt to start patients on opioids and especially continue to escalate opioid doses. Therefore, we're getting the patients earlier as well. I've been on the board of physicians in Maryland for 7.5 years. I don't believe I've yet seen an interventional pain doc, a fellowship trained pain doc, come before the board for opioid prescribing issues. I've seen, a few docs come before for behavioral issues and other issues, but not for prescribing issues. Whereas before the board, we've disciplined dozens of docs, especially primary care docs, for opioid prescribing, not having proper documentation, not offering alternatives, co-prescribing opioids with benzos excessively, et cetera. So I think the repositioning is really important for our field. One of the early business decisions that I made in running smart pain management before even we had equity involved was to have a strong compliance division and a strong compliance department. And that really helped me navigate some of these complex issues because there are a lot of regulatory concerns in pain management. And it's not just opioids, it's running ASCs, it's DME, it's if you're dispensing meds to patients, it's referrals to physical therapy and managing that, et cetera, et cetera, et cetera. So the decision I made to build a strong compliance vertical helped protect our organization, keep us clean, let us continue to grow and thrive, play the long game, so to speak. And I think some pain docs have not recognized the importance of having a strong compliance voice at the table. And sometimes they've made decisions for short-term financial gain over building and scaling an organization, playing the long game, so to speak.
Bridging that with acquisitions. So I imagine Clearway has been highly acquisitive over the years beyond cure pain. What are the cardinal rules that your organization won't break when it looks at an opportunity, regardless of price?
I think the first principle we have is know your partners. So we get to know our partners well and get a lot of comfort around our partners. And if we don't have the comfort that they're the right kind of people we want to partner with, that they don't have the right makeup, that they don't have the right risk tolerance, that they aren't growth oriented, then we decide not to partner with them. We want partners who have run very clean organizations, and we want people that we think we can work with. So, for example, yesterday we had been working on a potential acquisition. We had done a lot of financial diligence. I had met with the head of the potential practice twice. We were setting up another in-person visit. And we came across a news article from 4 to 5 years ago where this organization had been raided by the feds. So we immediately shut that down, canceled the upcoming meeting, and we're not going to continue conversations with them. And keeping our eye on the ball with making sure that we're keeping a clean organization and one that does the right things medically, I think is really important for us. And we really diligence that part of the business as well. It's not just the financials. Of course, you have to have a meeting of the mind on financials and valuation, and there needs to be upside for everybody involved. But if the other parts don't work, if the medical compliance part doesn't work, if the medical culture doesn't work, if the business culture doesn't work, then we're not moving forward. So we'll turn down many more opportunities than we get involved with on the diligence side and transact, because we need to make sure that we are picking the right partners. One bad acquisition, especially an acquisition of size, can set an organization like us back for years. And we know that, and we're very choosy in our partners.
Does that translate to extended due diligence processes? I imagine if you see something bankered, the whole goal of hiring an investment banker is to accelerate the process. How do you push back on a banker that wants exclusivity periods that are short, closing dates that are weeks away from a signed LOI?
We need to make sure that we have our time to do the diligence that we need to do. So we will push back. Again, we can be selective, and right now in the marketplace, there are not that many practices that are not. There aren't that many practices that are capable of completing an acquisition of size and scale right now. Some of the other organizations that aren't as big as us but are sizable are either highly levered or potentially over levered, and they are not as desirable as partners as us. We recognize that. So we need to make sure that we have the time that we need to do all of the diligence that we need to do. And the diligence, as you can imagine, is extensive before we get to the finish line and will effectuate a transaction with a potential partner.
That's a really good point, to be as aspirational as a buyer as the seller aspires to be themselves, to sort of level out the degree of leverage in controlling and influencing the risk of a transaction. So instead of all skewed towards the seller's benefit, to balance it out by being a buyer that a seller actually wants to partner with. It's a good test of how differentiated you are, what the seller is willing to do. Great point. Talk to me about Clearway Pain in the context of the musculoskeletal space ecosystem. One thing that we see time and time again with all participants in MSK is they love to become multidiscipline across the MSK spectrum. So from neuro to neuro-ortho, from ortho to pain, from pain to PT to podiatry, from podiatry to hand surgery. They rarely stay put. How have you thought about what that means as an opportunity and whether it's worth diversifying in that way, looking back and looking forward?
Yeah, I see us becoming more of a comprehensive MSK practice over time. And that means that we would like to incorporate physical therapy on a greater scale than we currently have. We have electrodiagnostics in many of our offices. We want to expand that across our practice to have that in all of our offices. We are positioning ourselves right now, about 75% of our book of business is spine related pain. And we are looking to become more of a one-stop shop, so to speak. So we're able to and market ourselves to do more knee pain, shoulder pain, hip pain, muscle pain conditions, peripheral nerve conditions. So our capabilities as an organization are there and will continue to expand in that aspect. I don't necessarily see us diluting our pain focus to have it be more of a multi-specialty type of an arrangement. We have had discussions about hiring orthopedic surgeons and neurosurgeons. Thus far, we haven't moved in that direction. That is a consideration, and perhaps that happens at some point, but I don't see us being a multi-specialty shop. Where I do see us potentially moving is we have multiple surgery centers and we're developing more surgery centers. And in a couple of surgery centers, we have now partnered with spine surgeons where we have majority of equity in the center, but we're offering equity to these surgeons. And that's a move where we're going to partner with these other specialties and perhaps podiatry and other specialties you mentioned, not under the practice umbrella, but in the surgery center, where we're partners in the surgery center, they maintain their autonomy. There may be some cross referrals and opportunities to work together through our partnership on the surgery center level.
Interesting. How large is Clearway Pain in terms of number of states, number of practices, number of providers?
Right now we're in 6 states, and we have heavy density in 5 of the 6 states. So, I'd rather have 50 offices in 1 state than 1 office in 50 states. So we're in 6 states with heavy density. Between surgery centers, offices, physical therapy locations, drug testing labs, we have over 100 doors now. In terms of number of providers, it's fluid because, for example, it's hiring season. We just hired a couple of additional docs even in the past week. So we have between 65 to 70 docs and about 140 to 145 total providers under Clearway right now.
And keeping that divide at the practice, or it's not even a divide, it's keeping other MSK physicians away from the practice. What is the concern there? Is it a question of distraction and complexity versus the ability to really fine-tune execution? Is that what's driving that decision, the need to really continue to invest in clinical outcomes, risk management as you scale further?
I think there's so much to do in pain management, and there's so much evolution and growth in pain management. We want to be a focused pain management practice. We want to position ourselves as a focused pain management practice. And again, we're open to some of those partnerships that you mentioned under the Clearway practice umbrella, but it hasn't been our primary focus right now and probably won't be in the near term. Where we think we can partner with these other practices in the surgery center, it's a matter of just driving outcomes, driving excellence in the pain space, and not entering spaces where we're less familiar, where there's additional oversight and risk. We also have thought about potential implications to referrals. For example, if we're partnering with orthopedic surgeons in a couple of our facilities in a certain geography, and how that would translate to referrals from multiple doctors across the entire region, if they understand that there may be competition if they make a referral to us by a doctor of the same discipline under the same roof. When we think of pain docs and how they're coming out of fellowship now versus even how I came out of fellowship in 2004, these docs are really bringing a diverse skill set and are trained to do a lot of high-end special procedures. And many of these procedures have just come to fruition in the past few years. So the offerings that we have are many minimally invasive procedures for back pain, for example, that can conflict with orthopedic surgeons. So if you're a pain doc and you go practicing in an orthopedic surgery practice, they're probably not going to allow you to do the full scale of pain management offerings that you can do in a pain practice such as ours. So, orthopedic surgeons in our practice may even feel a level of competition from our pain doc. So I can go through some of the specialization of procedures that our docs are able to do now. So for example, for vertebrogenic pain, there's a procedure called Intercept that has just come to fruition in the past few years. Endoscopic rhizotomies for facet-mediated pain, where patients have not responded to traditional facet rhizotomies. Reactivate, where we're putting stimulator leads along strategically along the multifidi in the back for ongoing chronic low back pain. Vertiflex for spinal stenosis, Minuteman for spinal stenosis, Mile for spinal stenosis, vertebroplasty for vertebral fractures, osteocool for painful vertebral tumors. So example, somebody has prostate cancer, has a tumor in the spine. A couple of years ago, you were limited to providing opioids. Now you can actually go ablate the tumor. So we're getting referrals from urologists. Dorsal root ganglion procedures for very targeted neuropathic pain. The technologies in spinal cord stimulation are burgeoning and really impressive. When I came out of fellowship, there were 2 or 3 spinal cord stimulator companies. Now there's 6 or 7, and the technologies are really evolving, and the capabilities of spinal cord stimulation are great. Via disc for disc degeneration. Now you can put a proprietary treatment into a disc for degeneration, and that has come to our docs in the past year or two. Spinal sacroiliac fusions for ongoing sacroiliac pain. When I came out of fellowship, we were doing just sacroiliac injections. Then we started doing rhizotomies of sacroiliac joints. Now many docs are doing fusions in pain management practices. Peripheral nerve stimulation for specific peripheral nerves. So the offerings in pain management are growing, and I think we need to be able to focus on what we can offer in pain and not dilute ourselves too far, but still, as you mentioned, be open to some of those potential partnerships if they make sense for all parties involved.
It's very exciting that the way that pain continues to reward you, as long as the principles that you maintain are the most important over time. And it seems like that's exactly the relationship you have with the pain category, to the point where you've become the aspirational buyer, right? You're the buyer that a practice wants to see walk through their door when they're looking for partnership. When you look, and this is my last question, then I'll open it up to the group. When you look at 6, 7 different growth opportunities that Clearway has in front of it, value-based care, strategic partnerships with health systems, ASCs, new patient market, patient demographics, new geography, new procedures, new payer categories, targeting the self-insured as an example, other ancillary revenues that are underdeveloped, clinical research, the use of technology, AI technology. There's a long list of potential ways to grow the business, and many that I haven't named. Which one gets you most excited, and why?
I think what gets me most excited is the evolution and growth in surgery centers and building surgery centers and watching them succeed. For us, having done this so many times, it's a relatively low risk endeavor with high reward. So I think that's our core competency, is ASC development. And I think the procedure shift and watching the young docs and some of the experienced docs advance their skill set is really exciting to me. I also love the fact that we have redefined ourselves, and we are no longer seen as people who just manage opioids and work to reduce opioids, and we're part of the problem. We're now, at least from what I can tell, seen very much as part of the solution with regards to the opioid problem in this country. We also are seeing less opioids, patients coming to us on less opioids, which is exciting to us. And just giving context to that, because I've made that comment a few times during this question and answer time. We have an external vendor that looks at our opioid prescribing, provides us a report. And in Maryland, for example, our MME, or morphine mill equivalents, which is a proxy for how much opioids are prescribed, tends to be about 32. In Florida, it's even lower, sometimes as low as 19 to 21. And the CDC came out in 2016 and said for primary care providers, they should use caution above 90 in prescribing. So we're seeing a much higher acuity complex patient with doses that are way below the CDC recommendation, any level of concern in our practice. And I think that's another thing that we're proud of is we have a very low dose opioid environment. We have a whole paradigm to recognize when we should test patients. Every patient, unbeknownst to them, gets a risk score attached to them, and that helps to drive how often we test patients and how comprehensive the testing is done. We continue to have that low opioid environment with a nice procedure shift and driving volume into surgery centers. I think that's what the future is for us in large part, and I think that's what gets me most excited is opening new centers, especially new surgery centers, and making them centers of excellence with broad offerings.
Okay, I want to open it up to the group. Does anyone have any more questions?
I have a question. Ira, thank you. Very interesting. When you're talking about at the end in terms of opioid use, I didn't hear any kinds of partnerships or programs that you had for mental health or addiction management as well. So I'm assuming that you are not drug seekers, all those kinds of things. You're trying to figure out what to do with them unless you're taking care of that yourself. How are you will, everyone has them, but my assumption is you probably have them more so than most other practices. How are you addressing that, partnering with and finding help for those patients for those kinds of services that you may not provide?
Oh, Andrew, great question. So we don't want to be a practice that does addiction treatment as well. We made that decision a long time ago. Now, there are a few patients here and there where we're prescribing Suboxone, but it's not a core focus of our practice, and it's not where we want to position ourselves in the market. So if we have aberrancies that are noted on drug testing, sometimes, depending on the level of aberrancy, we'll just discharge a patient and provide them referrals to others that we think are better equipped and more suited for that individual patient. Very often, we will let the patient know that we need to wean them down and that we will no longer prescribe them opioids, and send them a letter reflecting and memorializing that, and then also make a referral to a mental health provider that can help them cope with the reasons and understand the reasons for them having the aberrancy that we noted on drug testing. Early on during my practice, I did have a psychologist that managed many of these issues, and I felt eventually as though it was probably best for us not to hire a small army of psychologists and manage them, but to have resources that we can point to for our patients and make those referrals. We have a psychologist in-house who does mostly spinal cord stimulator evaluations and clearances for us, and periodically will help in this realm, but he's primarily focused and busy on spinal cord stimulation. So it is important, and I fully appreciate the question, to get these patients the help they need. But we've made the decision that we don't have to have that necessarily under our roof.
Question from Mark Maloney. You're welcome to come off mute, Mark, and ask the question, unless you want me to read it.
Oh, thanks. Are you in your network, are you using so-called pharma grade or European-based cannabidiol or CBD to be used as a non-opioid alternative?
We are not. I personally am not averse to that at all, but it's not something we're doing right now. And I think that's something that we can evaluate and be open to moving forward.
Thanks, Mark.
Thanks.
Any other questions for Ira? I want to double back, Ira, on this question of opioid addiction and the statistics that I saw. Maybe they've changed since I last read about it, but there was something like 2 million addicted to some opioid type substance here in the US, and from that, tens of thousands that die on an annual basis. Have we peaked in terms of the opioid crisis? Has the clinical community been able to absorb the realities of it at this point and build the infrastructure to try to mitigate down those numbers? What should we anticipate over the next 10 years?
Now, keep in mind that many of the opioid deaths, I know that people point back to the medical community and doctors as prescribing opioids as a big contributor to the problem. And it certainly is and has been a problem, and more so years ago. I think the level of opioid prescribing is down significantly. So the medical community contribution to the problem is reduced, which is phenomenal. Being on the Board of Physicians in Maryland, when we looked at this a number of years ago, we saw that actually 68% of the opioids in that state were prescribed by primary care providers. So, you know, tampering down on opioids for all providers, you know, I think is a good thing. Many of the deaths that are cited there are not tied back to opioid prescriptions from docs. You can get opioids from many different places. You know, there's certainly drugs coming across the border. There are drugs you can get online, and you know, drugs from many other places. So I'd say the medical community's contribution is less now, certainly, than it was 5 to 10 years ago. When I was training, there was a philosophy that pain is a fifth vital sign, that you should treat to effect, that you don't necessarily worry about over prescribing opioids. If patients are complaining of pain, you should continue to titrate up until you satisfy their pain with opioids. And then there was a recognition that that was a flawed philosophy, that the level of opioids needs to be less, and that, in fact, many times opioids are not indicated or not helpful in chronic pain situations. So early on in my career, it was not that crazy to see patients get 30 milligrams of oxycodone for breakthrough pain. I remember where I was practicing near Hopkins, sometimes we saw patients even coming from Hopkins at, you know, 800 milligrams of morphine equivalents. Now it would be exceedingly rare to see a patient on 30 and even 15 milligrams of oxycodone for breakthrough pain. I think the doses, the frequency of opioids is much less. So, you know, I'm comfortable with where we are and where we're heading. I'm certainly uncomfortable with where we were as a medical community. As terms of society, beyond the medical community component, it absolutely continues to be a big problem, and one that I think, you know, as a society, we need to continue to work on and do better.
It seems like we're left with a massive recreational drug use problem and almost a disconnect amongst users of the true risks that they face engaging in this type of drug use. And it seems like we go through different ways of drug use, and some drugs, depending on whether it's the 60s LSD or 80s crack cocaine or now opioids, at every stage, it takes a while for the older generation, the parental generation, and the younger generation to appreciate the extent to which they really can't afford to take those kinds of risks. So yeah, we're still in the middle stages of understanding the true extent of opioid hazards. Ira, I want to thank you for your time this morning. Really appreciate it. We all learned a lot, and we look forward to continuing to build our relationship.
Thank you, Roy, and I appreciate being here, and this was an honor, and happy to have any follow-up if I could be of any assistance.
Thank you. Take care.